the podium too, and he's going to talk to us about newborn screening and Hunter syndrome. He's well recognized in our region, has served for many, many years, and I'm just going to go ahead and let you.
Could you put my slide up? Thank you. It's certainly my distinct pleasure to give this lecture. I want to thank Serge and Ronnie in particular for the invitation. I knew Paul as probably as well as a lot of people who were not in Emory. And one of the things I remember about Paul is that he was very active in newborn screening and trying to advance newborn screening in Georgia. And he was the first person I heard the term diagnostic odyssey. I had not heard that. And that was probably now 15 years ago or more, but Paul sort of, and a lot of us have used that since, but he was the one that I first heard that. I don't know where that term first come from, but he really used that just to show the need for newborn screening. So now I want to turn my focus to what I'm going to do today is talk about, can I see my slides up here? Yep. Talk about the impact of new treatment strategies and newborn screening on Hunter syndrome. So what I'm going to do is give you this overview, and it's going to hopefully be tied together at the end. I just want to say that here's my credentials. I have the unique pleasure of now being the director of the Muenzer MPS Research and Treatment Center at UNC, which occurred in the last year. And this is a center that I'm going to hopefully in the future do a lot more, focusing on the well-being and improvement of MPS patients through an academic medical center, not through a patient support group. So that's sort of my unique sort of credentials there. I'm at UNC, Department of Pediatrics. I've been there for 29 years, and so I knew Paul for the whole time he was at Emory. So slides are not advancing. If you could just advance that, I can, oops. Thank you. As almost anybody in rare disorders areas have lots of conflict of interest. These are mine. I serve in a variety of advisory boards and consult for biotech companies, and I'm the principal investigator for a number of clinical trials, even though I'm slowly trying to back away from my clinical trial issue, but it's challenging. What I want to do is really give you a very brief overview of MPS. If you would let me, I would talk for a couple hours on just the MPS, but Ronnie won't let me do that. I'll briefly talk about pathophysiology, even though, again, these are topics we could spend a lot of time, and then really focus on MPS II and talk about the clinical features and the disease course a little bit. Talk about diagnosis, and particularly important related to newborn screening, as we now know that become part of the RUS for MPS II. Talk about the current treatment options for MPS II, and then really focus on the things that are going to change the outcome of our current patients with Hunter syndrome. One, some of the new treatment strategies that are happening, if these get approved, we'll see a dramatic improvement in outcome. And then more importantly, to be able to pick up patients before they have irreversible disease with newborn screening. So again, as most of you in the room know, the MPSs are a group of lysosomal storage diseases. But what you probably are maybe not aware, everybody, that this slide 6 months ago or a year ago had 11 known types, not 12. There's actually a new MPS type. The overall incidence, again, is either rare disorders, probably 1 in 25,000, maybe 1 in 20,000. But the overall incidence of each individual disorder is probably in the range of 1 in 100,000. We really don't know the true incidence. With newborn screening down the road, we'll get a better sense for that. As we all appreciate who take care of lysosomal disease patients, the hallmark is really the tissue storage of glycosamine glycans. Because these are housekeeping genes, these are progressive disorders, and they affect virtually every system in the body. And more importantly, for each disorder, there's a wide range of clinical involvement. It's just not a single disorder. It's really a heterogeneous disorder. And I'll just show this slide. Every individual in this slide has MPS. As you appreciate, they're all different types. Individual with Hunter syndrome, Hurler syndrome, MPS Sanfilippo, Meritotomy, just showing you example of the variability. And within each disorder, there's, as we'll see in Hunter syndrome, there's severe patients who have both neurological and somatic involvement to patients who only have somatic involvement or intellectually intact. One of the challenges for MPS is nomenclature. Historically, there was Hurler syndrome to equal MPS. And then there was the Hunter form of Hurler syndrome, even though in reality, Hunter syndrome was recognized, published a couple years before Hurler syndrome got published, but in reality, that's what happened. And then in the probably late 60s, probably McCusick and Hopkins really came up with the current nomenclature based on types and eponyms. And this just shows you that in MPS 1, everybody, all due to ironise deficiency, different forms. As you'll appreciate, Sly syndrome used to be MPS 5. Again, for Hunter syndromes, we recognize the mild form before somebody put their name on it. That is for MPS 1. Dr. Shea from Hopkins, an ophthalmologist, recognized, thought a new disorder that people were really surprised when enzymology came along, and it was really a very mild form of Hurler syndrome. In contrast, MPS 1 and 2, Sanfilippo, there was actually 4 different enzyme deficiencies. I should point out, in the mouse, there is 5 enzymatic deficiencies. There's probably another disorder to be diagnosed by hopefully one of you in the building today. MPS 1, 2, and 3 are by far the most common MPS disorders in the US. Morchio A and B are much rarer, involved in keratin sulfate metabolism. We no longer use 5. That was Shea. MPS 6, Meritotomy, is really a somatic disorder, intellectually intact individuals. Sly syndrome is very similar to Hurler syndrome due to beta-glucuronidase. A paper was published many years ago describing a new defect that was initially called MPS 8. That was retracted, so that's now blank. Now we have a few patients with hyaluronidase deficiency, and the newest disorder, there's a few patients with aerosulfatase K that may mimic a Morchio. It's still trying to clear what they look like, but so there's other disorders out there yet to be discovered. These are heterogeneous disorders. There's a spectrum of disease. MPS 1, 2, and 7 all have multisystemic somatic involvement and can have CNS disease, but they never only have CNS disease. Where in contrast, Sanfilippo was primarily a neurologic disorder where it affects really the central nervous system and somatic forms are mild. We now know with next-gen sequencing, there's a lot of very mild Sanfilippo patients out there that we never appreciated before. And I have now a number of 4 or 5 patients who are in the last 3 or 4 years who are over 25 years of age, were diagnosed because of developmental delay with next-gen sequencing, and people were amazed to find Sanfilippo syndrome. And you're going to see more of that. MPS 4 is a skeletal dysplasia, intellectually intact. MPS 7 is again a somatic disorder, intellectually intact. And then non-immune hydrops fatalis is the common presentation in the US of MPS 7. There's other lysosomal disorders, storage disorders that can have non-immune hydrops, but in terms of the MPS, it's really 7. What's the pathophysiology of the disease? Very briefly though, the amount of residual enzyme activity appears to be one of the major drivers of clinical severity. And I should point out the diagnostic assay is relatively insensitive and cannot pick up subtle differences. But if you have no activity versus a 0.5 or 1%, you have dramatic different disorder, but the diagnostic assay do not allow you to make that interpretation. So the diagnostic assay is great for saying you have MPS, particular disorder, but does not give you severity whatsoever. As we are aware, there's three major classes of glycosaminoglycans that are not equally found throughout the body. Heparan sulfate is primarily found in the central nervous system, dermatan sulfate in the somatic tissues, and keratan sulfate in the bone. So where these tissues are made is where they're stored, and that then results in some of the phenotypes. For example, heparan sulfate and Sanfilippo, they only have central nervous system disease, and they don't store a lot of dermatan, and that heparan sulfate in the brain causes the damage. Again, there's a unique glycosaminoglycan pattern for each of these disorders, which help dictate the clinical pictures. And again, it's more important to realize there's a variety of secondary events that really cause disruption in a lot of different pathways. GAGs are the primary storage, but what happens after the storage can be highly variable depending on the nature of the disorder, and that's what drives it. But if one can get rid of the stored GAGs, you should be able to prevent the disease. Here's just a brief slide. I won't go through it much, but talking about the major clinical manifestations of the MPS disorders. Virtually all organ systems are involved, but those of you who take care of other lysosomal storage diseases, you don't see kidney disease here, in contrast to like Fabry, where there's significant clinical involvement. We don't see renal involvement in MPS patients. We see hepatomegaly, but we never see liver failure. But otherwise, virtually all of the organ systems, joints, airway, cardiac, eyes, hearing, skeleton are all involved in the different MPS disorders to varying extents. So now let's switch gears in terms of that very brief overview and just talk more specifically about Hunter syndrome. So deficiency of the lysosomal enzyme ironate 2-sulfatase. Other people call it ironate sulfatase, the same name, just a different nomenclature. Unfortunately, about 2/3 of our MPS II patients have developed cognitive impairment. We refer to that as the neuronopathic or severe form. Onset of patients in the severe form is between 1 and 3 years of age. I should point out that MPS II patients, by and large, look absolutely normal at birth and probably don't develop disease until more 4 to 6 months or later in life, where in contrast, MPS I patients are normal at birth by and large, but within the first few months can already get a gibbous or other signs you can recognize for that disorder. All MPS patients have somatic involvement, typically cardiac and airway disease, but all do not have neurological involvement. That's where that 2/3, 1/3. In the severe form, the neurological patients untreated die in their teenage years, a combination of overwhelming neurologic disease superimposed on life-threatening cardiac airway obstruction and valvular disease to contribute to their demise. Even with treatment, by and large today, I'll talk in a second, we don't change the brain disease. Patients are living longer with just IV Elaprase, the IV form of ironate 2-sulfatase, but there's still that neurological component we'll talk about in a second. Again, in contrast to all the other MPSs, MPS II is X-linked recessive. It's an ultra-orphan disorder, as far as I'm concerned, and it's really common. 450 to 500 patients, I estimate, in all the US. You see it every day. I see it a lot of days, but most of you don't see it every day. It's incredibly rare, and this is one of the challenges for all the MPSs, because of the rarity. The average pediatrician, I estimate, sees 1 or 2 MPS patients in a lifetime of practice that they recognize. They don't always recognize them because of the delayed process. Carrier females have no obvious evidence of clinical disease by and large, where in contrast to Fabry patients, most of them, or majority of them, have clinical disease associated with their lysosomal storage disease. And we do see, though, a small number of females with MPS II due to non-random X inactivation or X autosomal translocation, which is how originally the gene location was identified because of an autosomal X translocation. As I alluded to, IV enzyme can help somatic disease, but does not help the brain, and there's a significant unmet need. This just shows you that spectrum of disease I talked about. The neuronopathic patient here, an adult who intellectually intact, but who has physical stomata. If you saw that patient your geneticist, genetic counselor saw that patient in clinic, you'd say, that patient has a storage disease. I may not know what it is, but that should say a storage disease. Lifespan is really, lifespan for the, didn't mean to go back so much. Lifespan for the attenuated really can be highly variable as a function of their airway status and their cardiac disease. And unfortunately, a number of the attenuated Hunter patients can have significant airway involvement at the right and left main stems and can die abruptly as young adults. Because of that, they have just a critical narrowing, get a little cold or something else to cause them to have a life-threatening obstruction. Patients with the neuropathic form tend to die in their teenage years of overwhelming neurological involvement, and they all develop, this cognitive impairment, which is a hallmark. What's the molecular genetics? Relatively small gene located on the long arm of the X chromosome, not too far from the fragile X site, and there's an occasional patient who has a contiguous gene syndrome where they actually have both deletion of the Hunter gene and of the fragile X site. When you have big rearrangements or deletions, these patients always have the severe or neuronopathic form. Because they have no enzyme whatsoever. They're really truly nulls. Unfortunately, most families have private mutations, which is very difficult to predict clinical severity, unless you have family members. And it tends to be relatively true within families. So I've never seen a family with clearly attenuated and a neuronopathic in the same family at all. That doesn't happen to my experience. The neuronopathic disease is really a devastating progressive neurologic disorder. They have onset of disease between 1 and 3 years of age. Unfortunately, they plateau some varying periods, and then they regress. And that regression is really, really difficult for families, and that regression results in the untreated patient, death in their teenage years. Some of the unique CNS features that occur in this population, they have hearing loss almost uniformly, typically at high frequency, and then going on to both sensory and neuroconductive loss. These patients can be really challenging to manage in terms of behavior problems. Similar to the Sanfilippo patients who have the same behavioral abnormality. They can really be challenging and hyperactive. Their hyperactivity peaks when they plateau, and as they regress, their hyperactivity actually gets better, but it's really a mixed blessing for the families because these patients are easier to deal with, but they're also harder to reach because they have lost abilities. Seizure are very common in the older patient as the brain deteriorates, and there's probably a 25 to 50% lifetime risk of having seizure in this population. By and large, they're relatively easy to treat with typical anticonvulsants, but it's still a challenge when you have seizures. Communicating hydrocephalus is a unique issue for the MPS patients, like the MPS II patients. They have a reabsorption defect, and that can be challenging to diagnose because it occurs much more chronically than the typical obstructive hydrocephalus. And again, I alluded to, there's really no treatment for the brain disease yet. So what's the definition of an MPS? They need evidence of GAG storage that can be either clinical features, hopefully, and or elevated urinary glycosaminoglycans. Glycans. They need to have deficiency enzyme. Those two things alone basically define the disorder. Before we had routine DNA sequencing, we could still make the diagnosis. Yes, it's nice to have the confirmatory evidence of DNA, but you don't always need it. What's the issue? How do you diagnose these patients? You got to think about them. If you don't think about them, you'll never make the diagnosis. I refer to as clinical suspicion, clinical suspicion, clinical suspicion. Think about them, and then you'll have a chance. You can do x-rays and show the dysostosis multiplex, which I haven't talked about. These days, quantitative urine GAG analysis, not dye-binding assays or toluene blue spots, but quantitative urine GAG with MS is really the way to go, both using the dye-binding and then individual components, dermatan, heparin, and keratin sulfate. Historically, I would estimate that we probably missed 25% of the Sanfilippo patients because they had a normal urine GAG. Now, with the newer technology, I don't think we're going to miss any of those. They have a much higher. And I would refer, not infrequently, a patient who looked like it's Sanfilippo, they didn't have any GAGs, and they said, what does the child have? When you do a more sophisticated analysis or do enzyme testing, you find your answer. But if it's any question whether the skeletal x-rays are abnormal, the urine gags are abnormal, or if you just have a high clinical suspicion, do the enzyme analysis. Every enzyme is available, and now that's really the way, the gold standard to sort of make the diagnosis. What about treatment options? Enzymatic correction has been possible at the cellular level in fibroblasts for probably 50 years or 40 years. And that's due to that cultured cells, really small amounts of lysosomal enzymes that my mentor, Liz Neufeld, initially termed correction factors. We also know there's a very efficient mannose-6-phosphate receptor-mediated uptake that can occur in fibroblasts and presumably in most cells in the body. But more importantly for the MPSs, we don't need 25 or 50%. 1 or 2% residual activity in a cell can normalize GAG metabolism. 1 or 2%. That's why some of these disorders we're dealing with MPSs have reasonable treatment outcomes for the tissue that can be reached. This term is cross-correction, where an enzyme goes into a cell and corrects the GAG storage. So what the two current treatment options for MPSs? Hematopoietic stem cells and intravenous enzyme replacement therapy. This is sort of my view of the world in terms of MPS as a treatment options, in terms of, I should say that for MPS 1, the severe form Hurler syndrome, the recommended treatment is hematopoietic stem cell transplantation before 2 years of age, and ideally under 6 months of age, where you get a much better outcome. IV enzyme is available for, you can see that there are 5 different MPSs, 1, 2, 4A, 6, and 7. But I just want to focus now on MPS 2 in terms of that. You can see here, hematopoietic stem cell transplantation works beautifully for the somatic disease in MPS 2 when done. For a long time, there was unclear how well it worked for CNS disease, and that's still a challenge. Compared to MPS 1, where there's probably maybe approaching now 1,000 patients historically worldwide transplanted with MPS 1 or Hurler syndrome, the experience is much more limited for MPS 2. As I alluded to, successful and stable engraftment for MPS 2 results in a form of enzyme replacement therapy. But as we all appreciate, transplantation is not benign. There's probably a minimum of 5 or 10% mortality, and depending who's doing it and when they do it, can be much higher than that. Historically, transplantation for MPS 2 did not benefit significant neurocognitive benefits. And most likely that the issue is these are older patients, because again, the MPS 2 patients with neuronopathic disease present later than the MPS 1 patients. So there's always this period of picking them up 2, 3, and 4, where we know transplanting a Hurler patient at 3 years of age, you do not impact their neurological disease, where transplanting at 6 months of age, you can get preservation of their cognitive ability. There's now some limited experience of transplant in younger MPS 2 patients that suggests some neurocognitive benefit. Unfortunately, there are really no guidelines yet of who we should transplant and when, and that needs to happen in the next few years. There's a recent publication that reviewed transplantation in MPS 2, and this is a quote from them: "The limited and heterogeneous data suggests that MPS 2 hematopoietic stem cell transplants can be effective therapy if performed early." It's not clear what early means, but it probably is under 6 months or a year of age, with modern transplantation technology that is using busulfan and other things to eliminate some of the toxicity, and getting a good matched donor. So that, even then, it's not clear whether we can impact the neurologic disease on everybody. Briefly, in terms of enzyme replacement, it's considered a standard of care for all MPS 2 patients. We know that ERT with idursulfase in MPS 2 results in reduction of urinary GAG excretion and decreased liver and spleen size in almost everybody. We see improved joint range of motion, pulmonary function, energy, and endurance occur in some patients after transplantation. Recombinant enzyme is clearly benefit for the physical disease, It's not benefit for the skeleton or carpal tunnel. And again, IV enzyme does not cross the brain. And there's still a huge unmet need in terms of IV or treating the brain disease, because IV enzyme does not impact that. Even though these patients are living longer because their airway and cardiac disease, if picked up early enough, are stabilized. So in terms of new treatment strategies, I just want to talk very briefly about 3 here. I could spend a couple hours talking about what's happening. I should say that historically, 25 years ago, there was no options in terms of treatment. Today, in the MPS community, there are greater than 25 to 30 companies that either have products already commercially available, have clinical trials in process, or have active preclinical programs looking at therapy. Incredible number of trials are going to come down the future. The current problem we have, which is a good problem, there's not enough patients for some of these trials. It's an interesting dilemma where 25 years ago, there was no trial. Now there's trials, but not enough patients, at least in the US. So first thing I want to talk about is the blood-brain barrier penetration. As most of you appreciate, we have this blood-brain barrier that's selective to the central nervous system, and it prevents a lot of things from getting in addition to these large glycoproteins we use for ERT, and so that's why the IV enzyme does not work for any of the MPSs in terms of brain disease. This just shows you an example of the different ways, but I want to focus on this so-called receptor-mediated transcytosis, where you basically, for example, transferrin brings iron into the brain, and there's a receptor, transferrin receptor, that takes it across. The mechanism, how it gets through 2 membranes, is still not very clear, but it does happen. And depending on how you engineer it, you can modify that. So I just want to talk about 2 different tech companies that are doing this. So one, JCR, has developed a recombinant protein called JR141 that consists of an antibody coupled to the iron 2 sulfatase. This antibody recognizes the human transferrin receptor, and it means to basically bind to that receptor and take it across. In this case, there's 2 moles of enzyme per molecule. This shows you in terms of this product given by weekly infusion at a dose of 2 milligrams per kilo has already been approved in Japan for the treatment of Hunter syndrome. And this is some of the data supporting that, showing the reduction of glycosemic glycans with this product in the brain, and more importantly, that patients who are either attenuated, or more important, a patient here who's in the early stages of Hunter syndrome do well, but if you already have significant disease, not surprising, you don't impact their brain, because there's a lot of irreversible changes typically once these patients are diagnosed clinically. It's important to recognize that CSF heparan sulfate, which is what that previous slide was, correlates well with brain tissue levels in animals. There's lots of good animal data supporting this. As you all appreciate, we cannot do brain biopsies on our patients, even though it's probably less benign than some things we do, but the concept is it's hard to get a brain biopsy approved. But just showing you here how as you lower CSF heparan sulfate, you lower brain neuronal gag storage. So JCR is currently enrolling a 2-year global phase 3 trial comparing JCR141 to idursulfase, that is Elaprase, in neuronopathic patients. In this case, they're doing an assessor blind, so either the patient is randomized either to study drug or not. The patient gets Elaprase, they go home. The patients who get JCR141 stay in the clinics, and then the assessor who's blinded to this sort of determines the outcome. So another company, Denali, has a similar product. In this case, they have fused 1 molecule of iduronate sulfase to a fragment of an immunoglobulin that binds to the transferrin receptor. A lot of differences in the affinity of binding, but the concepts are similar. To bind to the transferrin receptor and take it across into the brain. In a phase 1-2 study, which I'm part of, 45 patients received weekly enzyme infusion from a dose range of 3 milligrams per kilo to 30 milligrams per kilo. I should point out that this molecule is actually half ironite 2 sulfatase and half immune globulin. So a dose of 30 milligrams per kilo, that's a dose of 15 milligrams per kilo, that's 30 times the current Elaprase dose. So a huge difference in terms of dosing, which may have impact also. We see infusion reactions with both products. In general, they're well tolerated. In this case, in this early study, there was improvement in terms of the global impression scales. But more importantly, the next slide is really the key one for me. So this is a slide of CSF heparin sulfate. Here, showing patients had elevated CSF heparin sulfate, as you'd expect, because that's the heparin sulfate, that's the GAG that's stored in the brain, heparin sulfate. And what you can see is basically a normalization, not a 25 or 50% reduction, but a normalization of GAG. But more importantly, from my perspective, there were 2 patients in this study who had high pre-existing antibodies. And as you appreciate, patients who have null deletions, that is big rearrangement deletions, they unfortunately make high levels of persistent antibodies that are neutralizing that really do impact efficacy. In this case, this product appears to have neutralized or tolerized these patients, where Elaprase we've never seen that. So this has a unique feature. It's unclear whether the JCR product will do the same thing, but it may be the dose or it may be the nature of how the molecule is constructed, but it's a huge opportunity to treat severe patients. So Denali also is enrolling in a double-blind randomized trial, a phase 2/3, 2-year study where they're comparing DNL310, their product, at 15 milligrams per kilo, so 15-fold the Elaprase dose, to ironite hydrosulfate or Elaprase, and they're enrolling patients in that study. So that's the 2 sort of important trials in terms of IV enzyme therapy that's targeting the brain. The other one I want to talk about in terms of an MPS gene therapy trial, again, there's lots of experience in MPS in terms of gene therapy using either lentivirus or AAV virus. There's at least, and I'm probably not up to date, 14 human MPS gene therapy trials that have been completed or in progress. There's certainly no approved drug for MPS yet. But I want to talk about one company that has the most promising results, is REGENXBIO. They currently have a recruiting open-label phase 1/2/3 gene therapy trial for the neuronopathic or severe form, using intrathecal, putting the AAV vector 9 directly into the spinal fluid at the base of the neck. They're also incorporating, effectively a year's worth of immunosuppressive therapy to try to help that succeed. So as of earlier this year, 15 patients have been treated with RGX-121, basically well tolerated. At the highest dose cohort at 48 weeks, CSF heparin sulfate mediated reduction about 65%, and a specific GAG fragment which appears to have more toxicity than the general disaccharides they find, was 83% reduced. So good challenge in terms of biomarker reduction. I should say that REGENXBIO, we'll just do this and I'll come back to that. So they have some neurodevelopmental data, the patients who were not too impaired that are greater than a -2 standard deviation. So again, these patients all with neuronopathic are delayed, but if you're not too delayed, that is less than -2, you have basically a stabilization. If you're less, and some improvement, if you're more than -2 standard deviations, you tend not to do anywhere near as well. I want to go back and just say that REGENXBIO is actually trying to seek regulatory approval through an accelerated pathway. This accelerated pathway is actually using the biomarker CSF heparin sulfate and getting approval based on that alone, and then with the idea of having 5 to 8 years showing clinical efficacy. And I should say for rare disorders, the biomarkers should be the way to go because there's so few patients, they're so heterogeneous, and if we can show biomarker reduction, we know that from the CSF GAG data that if you have dramatic decrease in CSF GAG, you have dramatic decreases in brain GAGs. But one of the challenges is these patients with time of clinical diagnosis all have probably irreversible brain disease, so it's a challenge. But before I talk about newborn screening, some of you will ask me, and I'll just head this off, what's happening with intrathecal ERT for MPS II? I've been heavily involved in that project for probably 12 years or more. This study basically took males with cognitive impairment, so severe neuronopathic patients, all continued on weekly enzyme. At a part of a phase 2 trial, we gave them 10 milligrams intrathecal enzyme directly through by spinal tap or through a lumbar intrathecal drug delivery device that is basically a port in the spinal canal. The phase 2-3 data first year demonstrated the study did not meet its pre-specified primary or key secondary endpoint, but from a clinical perspective, the milder or less impaired patients actually have done dramatically well. And this is the challenge. This is a very heterogeneous trial, lots of different patients. The younger ones, the less impaired, really did much better. But Takeda is no longer seeking regulatory approval. These patients are still going to be treated through a compassionate program, and I really thank Takeda for doing that, but they didn't have to continue with that. How do you identify these patients? Because I already said to you that there's a lot of irreversible disease. And as you most appreciate, and certainly Paul FERNHOFF is very appropriate, he was a big advocate of newborn screening, as I am for these rare genetic disorders. If you look at this list as clinicians in the audience, a lot of those are very non-specific. Hearing loss, inguinal hernias, speech development, noisy breathing. Some of them are more decreased joint range and more specific. But until you have 2 or 3 of these together before typically they get diagnosed, and the typical patient has a diagnostic odyssey of 1 to 2 to 3 or 4 years even. It's not uncommon. I just recently saw a 4.5-year-old newly diagnosed with MPS II in my clinic. And in retrospect, he had clinical disease at 18 months. But nobody ever thought of Hunter syndrome, thought autism, this and that. He had 3 or 4 different diagnoses. And then finally somebody did next-gen sequencing, and lo and behold, he had Hunter syndrome. That's the hard way to do it. So what's newborn screening? For MPSs, it's really the measurement of the enzyme activity from dried blood spots using 4-metric or enzymatic assay using MSMS. It's very successful to do this. I should say in the asymptomatic individual with MPS II, low enzyme does not mean that the individual has a clinical diagnosis associated with that disorder. Just because you have decreased enzyme does not mean you have the diagnosis associated with that deficiency. I cannot say that enough because that's a significant issue because of so-called pseudodeficiencies, that is, variants that cause 95% reduction of enzyme activity, but that's not enough to cause clinical disease. Only when you get down to the 99 or maybe greater reduction do you have clinical disease. So do not put the diagnosis of, say, MPS II, because you have a newborn screen that's abnormal for MPS II. What you have is ironase deficiency. You don't have Hunter syndrome, which is a clinical diagnosis. Why screen for MPS II? Well, you already heard why. It's tough to make the diagnosis clinically. It's incredibly rare. And there's also no obvious features of a storage disease in the newborn period. I've examined now 5 or 6 newborns who were prenatally diagnosed with MPS II, and even looking hard, knowing that they had it, I could not be comfortable saying there was any obvious clinical feature that I could recognize. And I've only seen a few of these patients historically with the MPS population. That's joking, I've seen more than a few, a few hundreds. They have clinical disease at 1 or 2 years of age, with diagnosed typically much later. But there's a lot, 25 years ago I thought, we just give them enzyme and we'll take care of all their problems. We'll reverse everything. That was really naive thinking back then. There's probably far more irreversible disease than we recognize. The best you can hope for is really stabilization, not clinical benefit. And again, there's emerging evidence really showing, and not a lot, that early intervention really is much better than later. I think we'd all agree that if we could get enzyme to the patient earlier, we can do much better in terms of long-term outcome. And as most of you realize in the room, in August of 2020, MPS II was the second MPS added to the RUS after MPS I a number of years ago. So let's just show you how some of these issues are in terms of the Illinois data, that there's very few data. This is a recent paper by Barbara Burton's group. They did MPS II newborn screening by MSMS technology, or I should say Missouri is using the 4-metric assay, and both work. Both assays appear to be very successful. They started screening actually in December of 2017 and have over 500,000 babies screened to give you a reasonable size. Their cutoff was positive if the daily mean activity was less than 10% for that particular sample, and they had a borderline of 11 to 13, which in retrospect is probably not needed. There were 65 infants who had a positive screen, and then there's 11 who had 2 borderline results. And so they had 76 infants referred for diagnostic evaluation. 8 were positive in that group for MPS II based on decreased enzyme activity, increased urine GAGs or dried blood spot GAGs, and known pathogenic mutations, so clearly had MPS II. All of these had very reduced enzyme activity in the 0 to 2% range. So the 5 or 10% of the daily mean, those are pseudodeficiencies. They had 4 cases of attenuated, 3 with severe, and 1 phenotype could not be predicted. And it may be that with newborn screening, we're going to find more really mild attenuated patients. And that's one of the challenges of newborn screening. One of the problems is that, like in Sanfilippo now, we're picking up these patients who have developmental delay by next-gen sequencing who are 25 to 30. There probably are very mild Hunter patients out there, but the ones we really want to treat are the ones who are under in the childhood range. I'm not interested in treating somebody who only gets disease at 25 or 30 at the current time. So 53 cases with low enzyme activity had normal or mildly elevated urine GAGs. These are all pseudodeficiencies. So I think it's important to realize that you may have a little bit of GAGs depending on what assay you use. But again, this is one of the challenges for these pseudodeficiencies. We now know a lot of these variants, what they are, and so that's another way to rule out pseudodeficiencies. Again, 52 out of 53 had a positive IDS variant. More importantly for MPS II, given autosomal, giving X-linked recessive, cascade testing. If you're not sure what's going on, cascade tests that figure out maternal line, who else may be affected. And so, for example, one of the patients that was picked up in Illinois thought to have, significant disease, will have significant disease. There was a grandfather in India who was virtually normal with the same mutation. So cascade testing is so important if you can do it and you're available to help sort out what the history may be. So in terms of MPS II, confirm the positive newborn screen by measuring white blood cell or serum enzyme activity. This should apply to MPS I, too. Obtain urine GAG levels by measuring total GAGs by dye binding, and component analysis by LC-MS. That's so important because those two really sort of teach us this. We can pick out these milder forms much easier. Need to sequence the gene, and then if you have a patient who has a phenotype that's consistent with severe or neuropathic, I strongly recommend you start enzyme because they're going to have more severe disease. If you have a patient who has no clinical disease and genotype is consistent with attenuated, my recommendation is actually to wait for some clinical disease, and that's debatable. Some people won't, but I think that's a whole subject in itself. But I tend to, and I would only start treating at the first time because we recognize some of these patients may not get clinical disease to 10 or 20 years of age. And does enzyme really, can you start enzyme much later? My recommendation is to wait. That may be different. Everybody has to make their own decisions. In terms of newborn screening for MPS II, 2 states are currently doing it, Illinois and Missouri. Both North Carolina that I'm involved in and a pilot study in New York are involved in studies with MPS II. But I would guess in the next year there'll be a number of states who start newborn screening for MPS II based on what I've just described. So recommendations both for MPS I and MPS II newborn screening. Use enzyme activity as your initial screen in the bright blood spots. In contrast to Illinois, perform GAG analysis in the bright blood spot. It appears to be an incredibly great way to screen out whether you have storage or not on the same sample. If the bright blood spot GAG analysis is normal, these patients should never come to clinical attention. We a number of years ago in North Carolina, we did a pilot study for MPS I, and we had a 20-to-1 pseudodeficiency versus positive ratio. Illinois has similar to that. There's less pseudodeficiency than MPS II, but this idea of doing bright blood spot GAG should be the way to dramatically decrease your abnormal false positives. Again, if it's clearly abnormal, GAGs are abnormal, then this patient needs to be seen for enzyme confirmation, urine GAGs, and variant testing. So in summary, Hunter syndrome was a rare or ultra-orphan X-linked recessive lysosomal storage disease with many unmet medical needs, but it dramatically changed even with the start of IV enzyme years ago. The rarity and clinical heterogeneity typically results in diagnosis made only one significant irreversible disease has occurred. IV enzyme is available and beneficial in preventing somatic disease progression when started before the onset of disease. Once you have disease, you may not have the same benefit because, like, for example, the cardiac valve, once they start becoming abnormal, they really have a much different lifespan than a normal valve. There's no approved therapies for the CNS disease, but new therapies are showing promise in treating central nervous system disease, but should be done as early as possible for the best outcome. If you have a brain that's already significantly impaired, it's hard to change that. And newborn screening will allow the detection of patients prior to obvious disease onset, and the combination of new therapies and newborn screening in 5 to 10 years from now when some of these get approved, we should see a dramatic difference in the outcome for the Hunter syndrome patients. Thank you for your attention. Happy to take questions. I know this is a very vocal audience.